The core components of the foster care medical home really presents a framework for all of the parties to know exactly what their portion of the responsibility is as it relates to the foster care kids that we serve here in North Carolina. It helps all of the parties understand better exactly what their responsibilities are. So the primary medical provider has a critical role to play as it relates to the care of the foster care child, especially when DSS takes custody of that child. The critical elements really revolve around identifying the appropriate person in the practice to be the point of contact. The practice is so busy doing everything that it does every day to provide well child care, to provide sick care for its children, that when it comes to the foster care kids and the special needs that they have, having a point of contact that's really designated, that understands the needs of those children, the criticality with which they need to get into the practice to be seen, becomes really important. DSS fills a critical role as it relates to the fostering model, and that role really is multifaceted. It's important for them as well as it is for any of the other parties involved to identify a point of contact, of course, to ensure streamlined communication. What we have found in our network is it's critical for DSS to really understand what goes on in a physician practice. One of the things that we found in visiting practices is that DSS really didn't understand what the difference was between a well child check or a sick visit, and that there are different amounts of time that are associated with those visits. And quite frankly, when they would call to make an appointment with a primary care provider, they would say the child needed a checkup. So even working on a lot of the semantic pieces around definitions, what certain things mean, how to better communicate the need the DSS worker has related to getting that child into the practice is critical. It's also critical that DSS understand that upon the immediacy of taking custody of a child, that referral be made to the CC4C care manager so they can become immediately involved, not only in sharing information about the child back with DSS, but again, making sure that all of the medical needs are met for that child, helping the DSS understand that there's information available on the provider portal, that they can log into that information and see what the most recent medication fill history is, identify who the previous primary care provider has been, to make sure that, again, that there's a smooth process for the child as much as possible. So the critical requirements that CCNC or the CCNC network has within the fostering model really stand on being a connector. So the network is really filling the responsibility of being the connector. So it's finding and identifying a point of contact within the network to help not only the practice but also the DSS know exactly who it is to connect a child to connect a practice to, or who to facilitate communication through. It's very important for the networks to ensure that there is a fluid connection as it relates to CC4C care management, as it relates to primary care management, so that there can be another set of eyes and another set of hands around coordinating that child's care. One of the biggest learning opportunities that we had in our network was to help the providers understand the difference between an initial evaluation with a child and a 30-day comprehensive visit. Not only for the DSS providers to understand that there was a difference between the two, but to help ease some of the concern the primary care providers have, especially if they've never seen the child before. Primary care providers like to see children and do a comprehensive assessment, typically as their first visit, to get a better sense of what's going on with the child as they take them on as a part of their panel. What we did our best to educate our providers about was that when a child is first taken into custody, there are some immediate things that need to be addressed. Those things include any immediate needs a child has around medications, any immediate needs they have around other medical conditions that might need attention. So doing that in a very quick 15-minute visit really becomes the critical initial assessment of that child. We allayed the provider's concerns by saying within 30 days, we want you to bring that child back in and do all of those components of a well child check to really grow your relationship with the child. Growing this relationship with these partners, it has opened up new avenues of conversation that previously did not exist. We knew DSS was there. We knew DSS supplied a lot of the Medicaid enrollment components that we all work with in the CCNC networks. But I think better understanding how the work that they do in Child Protective Services relates to the kind of care management services that our CC4C care managers are providing really was quite eye-opening for us. So for our network in particular, the benefits of having the model is that it really provided for us a framework. It helped to provide a way for us to begin to have dialogue around specific topics. I think better understanding how the other side really sees this need for this child, I think it became very evident right away that all parties involved have a passion for taking care of these children and meeting these children's needs. So the importance of walking in each other's shoes, being able to have open dialogue, and really feeling like it's a safe place to ask questions and to get clarity about how to take the best care of these kids was really critical for our network.
The core components document relates to the letter of agreement in the sense that it outlines the roles, responsibilities, and expectations of each of the stakeholders. In the letter of agreement, it is mirrored information of the core components document under the roles and responsibilities section, but that is designed for us to be able to articulate clearly what each stakeholder's primary responsibilities are in the foster care medical home process. The function of the letter of agreement serves as a vehicle of communication for the stakeholders that are involved, where it expressly communicates what they believe their roles and responsibilities are, their expectations of the other stakeholders that are involved in the partnership. It allows for them to clearly define what they believe their primary responsibilities are and their roles within this foster care medical home process. And so that is the primary function of the letter of agreement, to serve as a vehicle of communication. An example of something that would be in the letter of agreement would be how the local DSS department will disseminate information between the medical home and the local community care network. The letter of agreement is not a legal document, nor is it a binding agreement. However, it does serve as an accountability document for all the stakeholders that are involved.